Hi, I just want to talk to you about chest tubes for a few minutes. We're going to talk about what the chest tube does, which patients get chest tubes, and a few other things like the nurse's role in managing a chest tube or assisting with insertion. The chest tube is designed to help maintain the negative pressure of the lungs. Some patients, if they're in a trauma or due to disease process or surgical interventions, may develop what's called a pneumothorax. And in a pneumothorax, there is air that gets into that pleural space, and that can start to collapse the lung. We put the chest tube in to allow for that lung to re-expand and a place for that air that's in that pleural space to start to escape. And we'll talk about the functions of that in a few minutes when we look at the devices, the drainage devices. Likewise, in a trauma or even in a surgery, they could get blood buildup in that pleural space, and that's called a hemothorax. Or they could have both air and blood in that pleural space, and that's called a hemopneumothorax. It's important for us to manage that, and by us, we as nurses don't put in the chest tube. The physician puts in the chest tube. But we need to manage it, because if it's not managed, then what will happen is that collapsed lung will start to push on the organs in the mediastinum. So remember, the organs in your mediastinum are your heart and your great vessels, and it can actually cause a collapse on the opposite side of where the injury occurred. That's called a tension pneumothorax. And a tension pneumothorax is a medical emergency. Now, if they already have a chest tube, it's due to an occlusion of that chest tube, whether there's a clot in it or some kind of kink. And so we need to figure that out. Troubleshoot the chest tube. If they do not have a chest tube and they're showing signs of a tension pneumothorax, which include extreme dyspnea, extreme dyspnea, a lower oxygen saturation. They're very air hungry, and you'll see chest rise on only one side of the chest. That is cardinal signs of the tension pneumothorax. If they don't have a chest tube, then a chest tube needs to be inserted. The chest tube itself functions, or the tube is inserted and it's connected to a chest drainage system, and you'll see pictures of that here in just a second. But the chest drainage system works under principles of water seal and negative pressure. So the suction helps create the negative pressure, and the water seal allows a place for that air to escape. So when the air is going out of that pleural space through the tube, it goes underwater in order to safely escape so that it doesn't bubble back into that chest tube. We look at the chest tube device for signs of that air escaping, and if they have a pneumothorax, we want there to be air escape. These days, there's two types of drainage devices. There's all kinds of manufacturers, but there's two main types. One is a water suction, and the nurse fills the container to the ordered level of suction, which is usually -20, and then you connect the device to the wall suction. But the water in that chamber does help maintain the right amount of ordered suction. And we're not seeing as many of those. You should have, when it's hooked up to suction, you should have bubbling in there, kind of like what you see in a fish tank, that kind of constant bubbling. And you hear that. Actually, a patient said that to me after their chest tube was removed. What happened to my fish tank? Where did it go? So that's one type. The other type is dry suction. And so on that device, and you'll see a picture here, that has a dial of suction. So you set the dial to the specific amount of suction for that. Any kind of device like that has a way of measuring the amount of drainage, and both of those devices have the water seal for the air to escape. The only difference is how the suction is controlled. There are also, if somebody has a pleural effusion, which is a buildup of pleural fluid, or like an excess of pleural fluid, that's caused for several reasons, sepsis, or they could have hypoalbuminemia. So remember that the albumin's purpose is to maintain osmotic pressure in the blood vessels, and so it needs to, I always symbolize it like this. It holds the blood in the right space inside the bloodstream. And if there's a leak or not enough albumin, there's places for the pleural fluid or the plasma to escape, and so it will leak into the pleural space. If the patient has a pleural effusion, they sometimes feel very short of breath. They breathe easier if they're sitting upright in the tripod position, but they'll also have a low oxygen saturation. And they'll put in a smaller tube called a pigtail tube or a pleural chest tube, and that just hooks up to a drain bag because we're not worried about air or a collapsed lung at that point. And so it looks like a bile bag or a small, like Foley catheter leg bag. You may have seen those at the bedside. And there's no suction on those and no need to maintain negative pressure. People who have a pneumothorax or people at risk for a pneumothorax include somebody who's had a trauma. A blunt force trauma could cause that collapsed lung. The pneumothorax could also be caused by disease processes and ventilator settings. Some ventilator settings can cause that, and sometimes invasive procedures. So when we talk about central lines, central line insertion can cause a pneumothorax. The other type is the hemothorax, and that is also when they have blood in the space. So think about a trauma that causes bleeding as well. A sucking chest wound, a stabbing, a bullet wound, anything that has caused that sucking chest wound. With that can cause both air and blood in that space. If somebody comes into the emergency room and you suspect that there is a pneumothorax, you're going to want to, until a chest tube can get inserted, you're going to want to put an occlusive dressing on it, and you want to tape it on 3 sides. You don't fully occlude that dressing because you want to make sure there's a place for the air to escape. So you want to do that, and obviously they need to get a chest tube inserted as soon as possible. The nurse's role in chest tube insertion is really dependent on which type of procedure it is. Sometimes this is done in the operating room, and that's a different role altogether. But if it's done at the bedside, the nurse's role is patient management. So on a traditional chest tube, the patient typically will be lying on the side, the unaffected side, and that area will be numbed. And my role, or your role as the nurse, is to help make sure that that area stays sterile, the sterile field stays sterile, and you're managing the patient, monitoring the vital signs, giving any sedation if it's ordered. Sometimes you're holding their arm up or pulling their arm back or whatever it takes so that they can get the chest tube in place. Sometimes it's pulling their arm forward. They're usually now done under ultrasound, so they actually have a good visual of where they're going. They'll usually numb the site with a little bit of lidocaine, and they will then put in a variety of tubes to guide wire it through. And then they put the chest tube in, and then we prepare this the drainage device, which we want to do before they start putting in the chest tube, and then we hook it up to suction. You want to tape all the connections, and then you hook it up to the wall suction and get things going. If it's a pleural tube, usually they prefer to have the patient sitting upright in the tripod position so that they can easily access it. Again, it's done under ultrasound. If the patient's not able to hold themselves upright, they will do it with the patient lying down, and it's the same thing. Sometimes my role is to just hold their arm out of the way or hold their hand while it's happening. Sometimes people need reminders even when they're sitting up to just, remind them to hold their hands and keep their hands in front of them. There are some complications that you need to be aware of. One thing is an air leak. So I'm assessing for an air leak in the water seal part. I do not expect bubbling in this water seal. If they have a pneumothorax and I want air to escape, then it's going to escape through bubbles in this water seal. You're going to see bubbles. And that's called an air leak. That's functionally what it's called. If the patient or the chest tube becomes disconnected in some way, and you don't expect an air leak, but you see one, that your first thing you need to do is look for the cause. It's usually that it's somehow loosened in the connection. And so you want to look for a cause. You want to protect the connections from accidental removal. So we usually tape all those connections. You always want to keep at the bedside rubber-tipped hemostats, 2 pair usually, a 250 ml bottle of normal saline or sterile water, and an air-occlusive dressing. So sometimes they're an emergency, and what happens is maybe the whole chest tube drainage thing falls over and breaks or something like that. You're on your way to x-ray, and the porter runs over the wheelchair and this breaks, and you don't have time to go back to, let's say that broke. You don't have time to go back to the floor to get a new one because now your patient might be compromised. You actually want to disconnect it from the device, disconnect the chest tube from the device, and then submerge the chest tube in sterile water. Radiology is aware of that issue, and so usually they know if a chest tube is coming, they're going to have the 250 ml of sterile water available, or normal saline, and you just submerge that in. It allows for that place for that air to escape. The other thing that happens is it accidentally comes out. Sometimes your patient pulls it out and they're holding it out at you as like, what's this tube? It must be a sword. And so if they accidentally remove it, then you want to put on occlusive dressing, but you want to tape it on 3 sides because there needs to be a place for that air to escape. And so you put the dressing on and you tape it on 3 sides. This is also the same thing you want to do if somebody comes into you with a stabbing chest wound, or an open chest wound, sorry, a sucking chest wound. For the immediate, put a dressing on it, but only tape it on 3 sides because you want a place for the air to escape.